a very warm welcome once again to all of you. So now let's go to today's webinar. So as you all know, our aim of doing this webinar is, and again, as you all know, people who have been attending regularly will know that every week, Fridays, we focus on one clinical skill which you can implement at the bedside. So that we hope would elevate your standard to achieve excellence. So this week, we are going to focus on best practices in nasogastric tube insertion and maintenance. That's this week's webinar. And as you all know, every week, apart from, I think, 1 week where our nursing training manager was involved, it's generally a didactic lecture given by Dr. Pari. So we thought, let us make it interactive and, 2 people involved, I think it'll just break the monotony. So I have also joined him this week. Dr. Parivalam Rajavellu, as you all know, is a consultant surgeon, Sundar Medical Foundation, and founder of Skillsomed. And he's, as people who've been listening to him will know, he's a very passionate teacher and a very good orator. So he loves to teach and loves to share his knowledge and wants his knowledge to reach as many people as possible. And one of his vision is to upskill nurses, to empower nurses. How do we do that? By providing them with knowledge and skills. So that is how we started Skillsomed, and that is why we are doing these webinars and courses. And I'm Dr. Nitya Pari. I'm the CEO of Skillsomed. I was working with TACT Academy as an academic coordinator for about 8 to 9 years. I have very good experience in training. And I left TACT and I joined Dr. Pari in his journey to upskill healthcare for safe patient care. I'm very happy I did that. And I'm very happy I'm here with all of you today. Yeah. So now we will start. I will just give a quick introduction about the nasogastric tube, which all of you must be familiar with, and then we will start with the session. So as you all know, nasogastric tube is a flexible tube inserted through the nose into the stomach. And so all of us know it's a very routine procedure and a very simple procedure. It's very important to know what are where all it can be used and how to properly insert it, how to maintain it, and how to monitor, because any procedure we do can land up in any complication. So what is NG tube and nasogastric tube? As the name says, it goes from nose into the stomach. So when is it used? Commonly used for decompression of stomach. Example, when there's a bowel obstruction or post-surgery, when the surgeon feels that he needs to decompress, you can put NG tube. And for enteral feeding, when the patient cannot take oral feeds, then we can put a nasogastric tube and feed them through that. And of course, medication. When the patient has a tube in place, you can definitely administer medication through that, which goes directly into the stomach and for better absorption. And for gastric lavage for patients who come with poisoning and overdose. So these are the common uses. And as I told you, it's very, very important to know about the how to do it properly, insert it properly, maintain and monitor it. That's what this whole session is going to be about. Excellent. So let's see what are the uses in the hospital. Where is NG tube used in the hospital? As you all know, it's particularly used in the critical care and surgical units. Then studies have shown that 5 to 10% of the hospitalized patients require NG tube placement. So it is quite a common procedure. And in the ICUs, you can see it's up to 40% of the critically ill patient needs an NG tube for enteral feed, enteral nutrition. Because, in ICU, most of them are on ventilator or there's some problem where they cannot eat. So they need NG tube for enteral nutrition. And then other problem, though we use it so commonly, as I told you, complications can happen. Misplacement occurs in up to 10% of the insertions. And so that is why we say that knowing how to do it properly and to have a verification protocol after inserting how to verify it. That's very, very important, because 10% of the patients who have NG tube inserted have it misplaced. So yeah, so the common complications are aspiration pneumonia, tube dislodgement, and because it goes through the nose, nasal trauma is another common thing that can happen. And all this can be prevented, complications can be prevented by following the best practices, which we'll be discussing as we go on. So today's agenda is going to be like, we're going to talk about, I gave you a little bit of introduction and importance of NG tube, that is already done. And Dr. Pari will be covering assessing the need for NG tube, preparation for NG tube insertion, and NG tube insertion verification, which I told you is very, very important, and troubleshooting and common insertion challenges, securing and maintaining the NG tube, nursing responsibilities in NG tube care, and managing, preventing complication, and ultimately safe removal. It's as important as insertion, is safe removal of NG tube. Yeah, so here we have a scenario of a 65-year-old male is admitted with the bowel obstruction, nausea and vomiting, and abdominal distension. The doctor's orders an NG tube for decompression. So now, actually, as I already told you, though it's a very common procedure, and it's very simple. It looks like a simple procedure, and I'm sure it's very important to know how to insert it. So, Dr. Pari, can you tell us what should be considered before insertion?
Thank you, Dr. Nitya, for that question. So first, I think what we need to do is assess the indication. Here already the surgeon has told that the patient has got intestinal obstruction, and therefore the indication is to empty the GI tract. The second is you have to consider if there are any contraindications before you actually insert it. Third, explain the procedure to the patient. Ensure its necessary equipment is ready, and then position the patient in the recumbent or sitting position. So these are the things which I want to first emphasize on. Let me just elaborate each one of these. So this slide shows the common contraindications for putting an NG tube. So the first on the list is a base of skull fracture or severe facial fractures. So here there is a danger of the NG tube getting into the brain or into the nasal cavities. So in this, it is not usually advisable to put an NG tube. Similarly, corrosive injections when a patient has swallowed corrosive and I put an NG tube, even partial thinning of the esophagus because of the corrosive can become a full-blown perforation if you put the NG tube inside. So definitely corrosive injection is a contraindication. Patients who had gastric bypass surgery may have abnormal anatomy, and therefore we might have difficulty in inserting the tube. So it may not be an absolute contraindication, but you have to face it with caution. Esophageal varices, again, not an absolute contraindication, but there's a danger that if you put an NG tube, it might actually dislodge the clot in the esophageal varices, and you can have more bleeding. Any obstruction in the nose, pharynx, and esophagus, patient with anatomical abnormalities, and if it's a very asthenic or unconscious patient with the risk of aspiration, you need to be cautious. So if you see, the first two are absolute contraindications: base of skull fracture and corrosive injections. The rest are all relative, and you need to use your clinical judgment to see whether you are going to put an NG tube or not. The second is explain the procedure. Most of the time, you don't actually tell the patient what actually they are going to go through. So we prepared a 6P checklist. Now, first you tell the purpose. Why is the NG tube needed? Second, you explain the process. Tell them exactly what will happen during the procedure. I'm going to put the tube into your nose and things like that. Okay. The third is, what will it feel like? So if you give them some example of how it will feel like, they may be anticipative of the procedure. 4 is patient control. You also have to tell them, no, you just are not helpless. You are in control. So I will just give an example of what actually we will say for this. And the 5th is precaution. What safety measures are in place? And the 6th is giving the patient peace of mind, reassure the patient and check their understanding. So these are the 6 P's of communication to explain the procedure. So I'm just going to give an example. Purpose, you say, hello, whatever the patient name is, Kupusami, I am Ramasamy, your doctor. And the doctor is, I'm a nurse or doctor, whatever. And I'm going to put the NG tube because, the doctor's advice decompression or for feeding or medication, whatever the indication is. And this will support your treatment journey. So that's the purpose. The process is, I will gently insert a thin flexible tube through your nose down to your throat into your stomach. This will help with the treatment, and the procedure takes a few minutes. So you've given them an idea what you're going to do. Next, you give them what they will experience. You might feel a slight irritation in your throat and mild discomfort, like when drinking a cold drink too fast. If you drink a too cold drink, ice cold drink very quickly, you will feel a pain in your throat. So you'll feel something like that. But certainly I've used lubrication, and you can sip water during the insertion to make it easier. And then you can say, if you're too uncomfortable anytime, you may not be able to talk, but if you raise your hand, I'll stop and pause immediately. So you are in control, so don't worry. And the precautions, I will confirm the correct placement before using it and ensure it is correctly placed in the stomach, and we follow strict procedures to prevent any complications. Finally, give the patient a peace of mind. I'll be there entire time, making sure you're comfortable. Do you have any concerns or questions before we begin? So this is the communication. There are no consent necessary for putting an NG tube, as far as I know. But if you communicate all these things and then get a verbal consent from them, definitely it'll go a long way in the patient satisfaction. So the next thing you need to be prepared is the equipment. So you need the NG tube, of course, a lubricant jelly, kidney tray, syringe, gloves, plastic apron, eye protection, a small glass of water, a straw if necessary for the patient to sip, and tape to secure the NG tube. The NG tube insertion is a clean procedure. It's not a sterile procedure, it's a clean procedure. So you can wear clean gloves and use the ANTT guidelines for a clean procedure for this particular insertion. And the normal position we use is the standard Fowler's, where the head end is raised about 45 to 60. Some patients may prefer a sitting, or some people who put an NG tube may prefer the patient sitting, so that it's easier for them to swallow the water, and also there's less chance of aspiration when they drink the water. So it's personal preference. Both the positions are okay. So that's what I will do, Dr. Nitya, to make sure once this patient is being, doctor has told me to put the NG tube, I'll make sure all these preparations are made.
Thank you, Dr. Par. Actually, what I best liked in this part was the 6 Ps, because it gives us the nurses, I mean, if every hospital, all the nurses have this in a form of scripted communication, so everybody will explain to the patient the same way, so that they don't miss out anything, any important point which they should convey to the patient. And as you said, it's going to improve the patient satisfaction and patient outcome. So that's a very nice way to, when you put it across about how to explain the procedure to the patient. So every procedure, I think it's important to have a scripted communication like this to improve. So because patients are so anxious, because we don't realize, we think it's a simple procedure, you just want to put some tube down the nose. But it's very important that they are made comfortable, and so that they'll be able to accept the procedure well.
Yeah, I think definitely scripted communication goes a long way, and you can quickly make these scripts and train your nurses on how to do about it.
So now, coming to the assessing the, before insertion, I think it's important to know how much of the tube should go in, because each patient, some are short, some people are tall, so they can be varied, length you have to use. So can you tell us how to estimate the correct tube length for every patient?
Certainly, I think it's a very simple technique. I think many of our audience will already know that, but just for the completeness, so you need to take the end of the NG tube from the tip of the nose to the lobe of the ear, and then extend it down to the xyphisternum, and then measure about, and add another 10 centimeters for anatomical variation, because some people might have a longer esophagus than the others. So this distance usually will be ensure that the tube gets into the middle of the stomach, into the fundus. So that's how you estimate the length of the insertion. So you can put a small micropore tape in that, where your finger is there in the xyphisternum. So that serves as a guide for you to insert it up till that length. Or you can note the reading in the NG tube and keep it in your mind. So no need, because we put in tape, then you have to remove it. So that will cause further discomfort to the patient. So in the measurement, you can note down whether it's 50 or 60 and make a mental note of it and insert the tube.
So now that we know what is the length of the tube that should go in, can you tell us what are the steps which are involved in inserting an NG tube correctly? As I told you, we need to know the best practices as to how to insert the NG tube. Can you please highlight us on?
Yeah, I think audience are following that. We are just following this case scenario, right?
Yeah.
So we first prepared ourselves and prepared the patient, positioned the patient. Then we measured the tube length, and now we are ready to insert the tube. But before that, I think we need to just brush quickly the anatomy in that area so that we sort of a mental picture how the tube is going in as we put in. So that will help us to sort of position the patient's head and also to point the tube as it goes along. So actually, if you see the nasal cavity, it goes along the floor of the nasal cavity into the nasopharynx. So when it hits here, this is where the patient will feel maximum discomfort. So once you get to that point of discomfort, you should stop and ask the patient to swallow. If they are unable to swallow, give them, that's why you have the water and the straw. Ask them to sip. So that will make sure the glottis closes and the esophagus opens up. The pharynx opens up and you'll be able to gently push the tube. So this is the anatomy, and you will also see why the base of skull fracture is contraindication. So if this part is fractured, then very easily the tube can get into the cerebral cavity. So a sound knowledge of anatomy will aid in the safe insertion of the tube. And also, just to again, for completeness, go through the various parts of the NG tube. So the tip, is soft, so that even if it pokes the esophagus or the stomach, it doesn't cause trauma. So it's soft and rounded, and reduces mucosal trauma, enhances patient support. And then there will be these beads. What do you call that?
Radio opaque.
Radio opaque beads there in the tip that will show where the tip is. Very important in ICU patients when you want to know whether it's actually in the stomach or it's in the esophagus or it's too much down. And then you also have this radio opaque strip all along showing where actually the tube is, which will be visible if you take an X-ray. And there are graduations which show the depth of the NG tube. And you have the side holes through which you can either aspirate or give the feeds through the NG tube. So these are the essential parts of the NG tube. And let me just show you a very good animation which I found in YouTube of how the NG tube goes into the various anatomical structures. So I'm just going to click on that 1 minute. Yeah. So you can see here, as I told you, the tube goes along the floor of the nasal cavity, right up, and then touches the posterior part of the nasopharynx. So once it does that, the patient feels discomfort. Then what you need to do is flex the knee, ask them to bend downwards. That's not shown in this animation. So that will also open up the esophagus and then sip the water. Then the glottis will close and then the tube will go into the esophagus along with the water. You can see the tube going into the esophagus along and then down into the stomach. So I thought this is a very good animation. So you don't need to imagine how the NG tube goes in. And this animation will help you in remembering that. So you asked me about the steps now. I'm going to come to the steps. So the first thing is to lubricate the tube with water soluble jelly. And you can bend the tip of the NG tube just a little bit. Some people say, you can put it in ice and all that. No, not required. NG tube is stiff and it will have a little bit of memory. So you just bend the tip down to about 30-40 degrees and then slowly insert the tube through the nose, guiding it downwards. Don't put it up. So guide it down so that it is along the floor of the nasal cavity. So once the patient feels the back of the throat, stop. Ask the patient to bend the neck forwards like this and ask them to sip the water and keep pushing it in, with uniform but gentle pressure. So you should always hold the NG tube with just your index and thumb, so that there is less, as if we hold a pen, so there's less amount of pressure you can do. So you already measured the length. So you insert up to the measured length and secure the tube with the adhesive tape. So that's how you, what are the steps involved in the NG tube.
Yeah, so now that we've inserted the NG tube, as I mentioned earlier, to avoid misplacement, verification is very, very important. Verification of placement is very important. So can you tell us how to verify the NG tube placement, Dr. Pari?
Yeah, there are actually, several methods. As we saw in the poll, majority of us use the, insufflation auscultation method. So either you aspirate it and see, okay, I'm very clear, aspirate, so it's in the stomach, and you then, inject the syringe, put the stent over the epigastrium, and you hear the whoosh sound, and you are satisfied that it is in there. But if you want to be more careful, whatever you aspirated, you have a pH strip, and you put that pH, this fluid on the pH strip. It should show acid, the color equivalent to the acid range. And X-ray verification is certainly important in the ICU when the patient is unconscious, and also when you are going to start feeding. So you should never start feeding without X-ray verification. The other very simple method, which mostly I don't see being practiced, is as soon as you put and fix the tube onto the nose, use a tape and measure the external length of the tube. So this is a very good indicator. When next time you go before feeding, you can just check it with the tape. And this external length, as long as it remains safe, you know that the tube has not slipped out or it is slipped in. So it's a very useful thing to do. So many studies have shown that you should not just be satisfied just with the aspiration and auscultation method, but you should use at least one more. Either X-ray verification or pH testing is required. So I know best practice is using two of these methodologies to verify the correct placement. So when do you check the placement? After initial insertion, of course. After administration, before administration of each feed, as I said, told you, before giving drugs, because it's very dangerous to give it in the wrong place, right? Both the feeds and the drug. And if the patient is on continuous feeds, at least once daily during, you should check it. Whenever the patient has had an episode of vomiting, retching, coughing, very, very high chance that it may be displaced. So definitely you should check again. And if you are doubting that there is tube displacement clinically, again you will check. So I think you need to write in your SOP, NG tube SOP. Now this is very, very important. All these factors which I explained in this slide are very important. It should be part of your SOP. So that's how you verify the correct placement, and also when to verify also I have detailed here.
So probably when they move the patient, when they...
Mobilizing the patient from one ward to other, yeah, I think that's very valid. I think we should include it next time. Yeah. So yes, that is very important. Suppose they're moving from ICU to ward or from theater to ward. So before using it again, you should check it. I think that's a very valid point. Anything else you want to add?
No, nothing. Yeah, thank you. Yeah, so now we have learned how to insert, how to check the placement, and what should be done. So while we're inserting, many a times, as many of them pointed out in the poll, that they feel a resistance, that's one of the problems they have when they're inserting. So what should be done if there's a resistance met while inserting? Can you please tell us?
I think the first thing to do is to stop, right? So whenever there is a resistance, don't blindly push it. No, stop, withdraw the tube to a small length, and then reassess. Okay. So stop and reassess anatomy, very important. So if you repeatedly you find that you're unable to push it through, so you may try the other nostril and maybe use a little bit more lubrication. Okay, so that is simple things to do. But on the other hand, if you insert it and the patient starts coughing and becomes blue, definitely you have put it in the trachea. So immediately remove it, allow the patient some time to recover, connect him to a pulse oximeter, make sure the saturation is okay. Leave it for about 15 minutes to half an hour so that the patient is rested, and then you can try, or if you're not sure, call your senior. So that's very important. And if you put the tube fully in and you don't find a gastric aspirate, you can flush it with air. Don't flush it with water or fluid because it may be in the trachea, right? So you can flush a little bit of air and then attempt aspiration again. If still there is no fluid coming out, gastric aspirate coming out, and then I think we need an X-ray to make sure that the position is okay. So this is how I will troubleshoot any insertion problems.
Thank you, Dr. Pari, about that. How should now, see, actually inserting, if you don't fix, after insertion, if you don't fix the tube properly, the problem is can either go inside or come out. So very important to know how to fix the tube, secure the tube properly and maintain it, maintain the tube as well. So can you please tell us how to secure it and maintain the NG tube?
Yeah, so I think we need to use a skin-friendly adhesive tape. I've sort of tried to get outside this discussion of whether we need to put micropore or elastoplast, right? So many hospitals use elastoplast because, as you know, many of the noses are very oily, and the normal micropore, if you put, then they don't stick properly. It gets a bit loose, or if it becomes wet, easily the micropore becomes loose. So many hospitals will use a elastoplast, but it's not very friendly on the skin. But we need to balance it. So it's an individual preference and hospital policy. And another important thing I wanted to point out is we need to rotate the tube every 2 days to prevent pressure sores. What do you mean by rotate is not rotate from one nostril to another. Loosen the tape and then rotate it a little bit, wait for about 2 minutes and then fix it again. One, it'll, the nasogastric tube may be hitting against the nostril or the septum and causing pressure. So by rotating it, actually, you're sort of taking it out of that pressure area, and also gives a little bit of relief to the patient that the tape is out for about 2 or 3 minutes, and then you can put it in. It's a very good practice. Again, not much practiced. I think we all should do it. So as I said, rotating the NG tube every day helps to prevent pressure ulcers or skin breakdown in the nose and the upper lip. So here is again a nice animation of how to fix it. Here they use good micropore-like tape, and it's a very good technique. So you just have to take a length of micropore, split it into two, and the area which you have not split, put on the bridge of the nose, and then you roll it over. See that folding? I really like that. Okay, I hope you notice that. Let me play it again. It was very small. This is important again. Many times I find this is not done. The nasogastric tube is dangling from this nose, and that causes so much of discomfort to the patient. Very simple procedure is to fix it to the side of the cheek or the neck. Neck is a little bit mobile, so it has to be side of the cheek or the shoulder. And see, there has to be a mesentery. Don't just fix it flat on the skin. That will cause again discomfort in the tube moves. So just like the intestine, which is mobile, the small bowel is mobile. This tube is also mobile. So you need to have a small mesentery on the tape and then fix it onto the skin. Okay, so the thing about fold, see, this is the cleaning it nicely so that it sticks very well. Don't put tincture benzoin or anything near the nose. It's very irritant to the eyes. So just clean it with nice saline or maximum chlorhexidine. Split the tape, 2/3 of the tape, fix it, roll it one side, roll it the other side, and the edge just fold it. This will help you to remove it very easily. And then put another length on top. Very nice method, and then fix it to the cheek. If the patient is not comfortable with that, fix it to the shoulder. So, and this is the mesentery I was telling about. Okay, so that's how, it's a small thing, and I was spending 5 minutes on fixing, but it makes a lot of difference to the comfort of the patient. Many times I find that, this it's hand dangling down, it's pulling down, patients are so uncomfortable. I really feel sad that we've not done the simple fixation.
That was a very brilliant video, because I think, as we pointed out, fixing is very, very important, because that will prevent, tube coming out or going. And this was a very nice video. Yeah. So now insertion, as Dr. Pari mentioned, could be done by anybody. Either nurse could do or doctor could do it. But who's going to maintain it? It's the nurses. So can you tell us what are the key nursing responsibilities for a patient with the NG tube in?
Yeah, basically 3 things. One is monitoring. As we pointed out, it should stay in place and while moving the patient. So check regularly. All those indications I mentioned before. Check it regularly to detect displacement. Check for complications, and record the insertion time. What tube length was inserted? This is all very important. And what is the length of the tube you measured outside? Also can be recorded, so that the next shift nurse, before doing any giving medication or feeds, can just verify that. So there's documentation, and the third is charting in the input-output chart. So the input and output has to be charted, and of course you need to replace the aspirated fluids. If it's like in the patient is intestinal obstruction, you may have within a short time 2 to 3 liters of fluid coming out. So you need to replace the losses by intravenous route, because in intestinal obstruction you cannot feed the patient. So ideal solution to replace gastric aspirate is ringle active solution. So use that to replace the aspirated fluid, and also look after the patient. Hygiene, brush the patient teeth twice daily to prevent infections. As I said, untape and rotate the tube every 2 days, and educate the patient that they don't pull on they're careful that they have the tube, and you should guide them on the decompression and feeding frequency. How often you are going to aspirate? Is it hourly, second hourly, or fourth hourly? You tell the patient, educate the patient that this is what I'll be doing. Or if you're going to give the feed, either it's going to be a continuous feed through the machine, to the infusion pump, or it is going to be intermittent feeding using a syringe. You have to educate the patient. So this is what I would say in short, the nursing responsibilities when a patient is on NG tube.
Thank you for explaining that. And yeah, so as we, any procedure, as I told you earlier, that has complications. So there's no procedure without any complication. So Dr. Pari now will tell us about what the common complications and how you can prevent it. So can you please highlight us on that?
Yeah, the common complications can be classified into minor or major. Minor skin excoriations, small nasal bleeds. Very common is pharyngitis. They all complain of sore throat. Reflux esophagitis. It may aggravate the reflux, and patients also develop acute sinusitis. These are minor complications. Major are aspiration pneumonia, severe trauma to the nostril like pressure ulcers, misplacement into the lung or skull base. Esophageal perforation has also been noted by the use of NG tube, and vagal nerve stimulation causing arrhythmias, bradycardia, fainting attacks also has been reported. So these are the complications. So let me quickly go through the prevention strategy. So the prevention for skin excoriation we already explained. Nosebleed is adequate lubrication, correct tube size. I think we didn't emphasize this enough. Always know if it is just for therapeutic drainage, unless your doctor tells put a larger tube, put the smallest size possible. Okay, don't put this large unless there is a hematemesis, there are clots, you want to do a lavage, then you put a large size. Otherwise, small tubes is more than enough. Oral hygiene and proper tube positioning will reduce the incidence of pharyngitis. Keeping the head of the bed elevated in ICU. This is the VAP protocol, VAP protocol, 30-degree. One of the thing to reduce ventilator associated pneumonia is keeping the bed elevated. Sinusitis, avoid prolonged use. Switch nostrils if you need to keep it for more than 5 to 7 days. Aspiration pneumonia, I think the best way is to ensure that the placement is okay with, and along with the auscultation, pH or X-ray. Always nurse the patient semi-upright. And the trauma, we already talked about. We also talked about the misplacement in the lungs and skull base. Okay, skull base, you can avoid if you totally don't put the NG tube when the patient has got a fracture of the base of skull. Okay, and esophageal perforation, this is because of very hard pushing. So as I told, when there is resistance, stop, pause, withdraw, and then reassess, then slowly try to do it. If it is more resistance more than 2 or 3 times, stop it, pull out the tube, and ask for experienced people to do it. Vagal thing happens if you try to push the tube very quickly, and so very gentle passage of the tube will actually reduce the vagal nerve stimulation. So that's about the complications and how we can prevent them.
Yes. So as important as it is to know how to insert it carefully and following the best practices, I think it's as important to know how to safely remove an NG tube. It may be simple, just remove it. But then we have to know how to safely remove, again, not to cause much discomfort to the patient, and explaining to everything what we did for insertion should be done for removal as well. So can you tell us, Dr. Pari, how to safely remove the NG tube?
Yeah, not as elaborate as insertion.
Yeah.
A few points. Flush with 20 to 20 ml of water. Why? Because if you put the tube in for some time, it can stick to the mucosa. And there may be excoriations, and it could be fixed. And if you pull it, then there may be some bleeding from the mucosa. So if you flush it, then it loosens that stickiness onto the mucosa. So very important to flush it with 10 to 20 ml of water, and then instruct the patient to hold the breath. Just say, I'm going to remove it. Take a deep breath and hold for just 2 or 3 seconds. So as they hold in a smooth action, remove the whole NG tube. Don't do it in stages. The anticipation, the patient will start retching and all that. So most of the time, before they even realize the tube should be out, smooth, but quick movement, you should remove the whole NG tube. After that, they may cough, but then there's no danger of aspiration because the tube is not there. So this is a very simple way, flushing, instructing the patient, and then removing it in a very smooth and swift manner. And observe for any signs of bleeding or discomfort. After that, stay by the side for at least 2 to 3 minutes. Make sure they are comfortable, settle down, and then you can come out of the room. There's one thing is there is a mnemonic called SAVES when you have problems in removing the NG tube. So stop if resistance is felt. When you're removing it, if you feel resistance, again, don't just yank it out. So stop, ask the patient to open the mouth, visualize the tube. So in the mouth, you'll be able to see many, some very rarely, the NG tube twists on itself and forms a knot. So this is known as the lariat knot loop. So used in the farms, right? So it's like a suruku. So that you can, like a lasso. So you sort of avoid by asking them to open the mouth. If there is knots, then you cannot pull it. So you need to actually cut the tube and take it out through the mouth. So you need assistance, you need the Desjardins forceps and all that. So you need to be equipped with that. So if you feel the knot, you ask for help, get all the equipment, and then remove it. Then evaluate tube positioning and summon help if removal is difficult. So I think if this acronym is remembered, so when you have resistance while pulling out, stop, ask the patient to open to see if there's any knotting. If there is no knot, then reassure the patient and slowly you can pull it, or flush the tube and pull it. Then evaluate the tube position. If it's not coming out, then again better to take a X-ray and find out what the position is before removing it, and also get help. So I think that's what I wanted to talk to you about safe removal.
Thank you, Dr. Pari. So that was a nice mnemonic to remember when there is resistance, what to do. And as you rightly pointed, call for help. Anytime we have a problem, I think you never feel bad about calling for help. I think it's important we just shout for help. However senior we are, we just ask for help, and so that we don't cause much trouble and harm to the patient. So because we're talking so much about patient safety, that's very, very important. Yes,
I
next.
think coming to the end of the presentation, I would ask
Yes.
you to go through the key takeaways.
Okay, yeah. So let me now go through the key takeaways on insertion. And I think Dr. Pari very clearly and very nicely told us how to insert it correctly. First of all, before insertion, we need to measure correctly. So that from for every patient, you need to measure from earlobe, nose to earlobe to Ziffy sternum plus 10 centimeter. And he explained it clearly. And then ensure proper positioning. Insert the tube, and make sure you insert it following the best practices and secure it well. As I told you, it's a very lovely video, though we repeated it again and again. I think that was really especially for those who are learning for the first time, the junior staff. I think that's a very good video. And then is after placement, confirming placement is very, very important, because there are chances of misplacement by pH testing, X-ray if needed. And of course, Dr. Pari mentioned the other two confirmation tests as well. That is on, what's it?
Auscultation,
Auscultation, aspiration.
the
And
length of
length, yeah, monitoring the length of the tube which is outside, yeah. Then monitoring and maintaining the NG tube. Again, this is a very great responsibility of the nurses. So we need to regularly flush it to prevent block, or flush it before and after giving feeds or medication. And then oral care is very, very important. You can't leave it like that for long without oral care. And we have to make sure the blockages are prevented by regular flushing. Then, as I mentioned to you earlier, of course, as Dr. Pari said, it's not an elaborate procedure for removal, but it's always good to explain to the patient and tell them what they're going to expect while removing as well. And then flush it and instruct the patient to hold the breath and remove it smoothly. Just, it's a smooth one, at a one stretch, like, not interrupted or jerky mode. Just a one smooth movement, remove it. So that will help to prevent discomfort for the patient.
Thank you so much, and let's meet next Friday. Thank you.
Thank you, Dr. Pari, and thank you all so much for joining. Thank you so much.